In 2023, the US FDA approved SYFOVRE, which is pegcetacoplan, and IZERVAY, which is avacincaptad pegol, for the treatment of geographic atrophy secondary to age-related macular degeneration, or AMD. Both products have a novel mechanism of action approved for this indication by targeting the immune complement system. Let's discuss a little bit on geographic atrophy related AMD and how SYFOVRE and IZERVAY are different. The information presented in this video should not be used for diagnosing or treating a health problem. Consult your healthcare provider before making any changes to your health plan. Remember to subscribe to this channel so you can be notified of more pharmacy and medicine related videos. Geographic atrophy is an advanced form of dry, age-related macular degeneration, or AMD, that causes cell death in areas of the retina, impairing central vision and can lead to irreversible vision loss. Typically, geographic atrophy affects both eyes. If you have geographic atrophy, you'll have blind spots, also called scotoma, in your central view, and you'll lose some sharpness of vision. Researchers believe the immune system, specifically the complement cascade, plays a role, and we'll discuss that in a couple of minutes. If you have geographic atrophy, your normal daily activities will be affected. You may have difficulty reading, driving, difficulty recognizing faces, or perform any other tasks that rely on central vision. On the right side in this picture, this is a color fundus photograph from two patients with macular geographic atrophy. The margins of the regions of the retinal pigment epithelium atrophy are clearly delineated by the arrowheads. The choroidal blood vessels, indicated by the arrows, are more easily visualized in these regions of atrophy because of the loss and or absence of the retinal pigment epithelium pigment. A choroidal nevus, marked by the asterisk, is indicated in IA. These eyes would be expected to have poor central vision due to extensive atrophy. Now some more data on geographic atrophy. Nearly 20 million people in the United States have some form of AMD, of which 1 million people have geographic atrophy. Geographic atrophy, again, is a late stage or last stage of AMD. 8 million people globally have been estimated to have geographic atrophy. GA accounts for 20% of all legal blindness attributed to AMD. The prevalence of GA increases with age. Starting at age 50, prevalence quadruples every 10 years. The risk of developing GA increases as dry AMD advances from early to intermediate with age, and there is some evidence that risk of GA also increases with certain risk factors such as smoking or a history of smoking, lens opacities, previous cataract surgeries, poor visual acuity at baseline, obesity, cardiovascular disease, diabetes, and high cholesterol. Symptoms of GA include difficulty adapting to low light levels, need for brighter light, images appear with decreased intensity of brightness, reduced central vision, blurriness of printed words, visual distortions, and difficulty in recognizing faces, for example. For diagnosis, imaging and visual acuity tests are performed, such as fundus autofluorescence, optical coherence tomography, microperimetry, multifocal electroretinography. In terms of management, there are some new treatment options available, which we'll discuss. In addition, patients may undergo one or more of the following: perform visual rehabilitation. This means perhaps wearing prescription eyewear, obtaining visual aids like a magnifying glass, or learning to manage activities of daily living. Vitamin supplementation such as the AREDS2 or 1 can be taken, and these are vitamins that include beta-carotene, lutein, zeaxanthin, vitamin E, zinc oxide, cupric oxide, for example. Also possible is implantable miniature telescope. So your surgeon replaces your lens with an IMT. The device magnifies things in your central vision and focuses them on other areas of your retina that are still working. Now let's talk a little bit about the proposed pathophysiology of AMD and its relation to the complement cascade or the immune complement system. The pathophysiology of dry age-related macular degeneration and specifically geographic atrophy has been linked to the complement cascade. This cascade is part of the innate immune system and is made up of the classical, alternative, and lectin pathways as described in the diagram on the right. The pathways comprise a system of plasma and membrane-associated serum proteins that are activated with identification of a non-self entity. A number of these proteins have been implicated in the development and progression of dry AMD. The three pathways converge at the C3 protein and cascade down through C5, making both of these proteins viable targets for the treatment of dry AMD. In addition, there are a number of complement factors, CFB, CFD, CFH, and CFI, which are potential targets as well. Now, we won't go into the complement cascade in detail, as it would require its own video. But for the time being, just note that multiple studies have implicated complement activation as a key component in the development and progression of geographic atrophy. Complement proteins, age increases in the upregulation of complement genes, and related accumulation of the membrane attack complex, or MAC, and inflammatory cytokines and chemokines found in the retina have supported this hypothesis. Abnormalities in the function of the proteins associated with the complement system lead to an imbalance of homeostasis, often resulting in damage to healthy tissue. AMD and consequently GA have recently been added to the long list of diseases associated with such abnormalities within the complement system. However, currently there is not enough clinical data to provide insight into the specific locations in the complement cascade that affect the development and progression of GA. Upregulation of CFH, CFB, CFD, CFI, CI, C3, and C5 are thought to present as risk factors for both the development and progression of GA. As more research is done, we will gain more additional specific insight onto how these complement factors affect diseases such as AMD leading to GA. The two products that we'll be talking about, SYFOVRE first, binds to the complement protein C3, and as indicated by the arrow, you can see where C3 is. And its activation fragment C3b with high affinity, thereby regulating the cleavage of C3 and the generation of downstream effectors of complement activation. IZERVAY binds to and inhibits complement protein C5, and as indicated by the arrow, you can see where C5 is. By inhibiting C5, IZERVAY may prevent its cleavage to C5a and C5b, thus decreasing MAC formation. Now let's talk about the efficacy data from the phase 3 studies for both products. First, for IZERVAY, the FDA approval for IZERVAY was based on the GATHER1 and GATHER2 phase 3 clinical trials, which evaluated the safety and efficacy of monthly 2 milligram intravitreal administration of IZERVAY in patients with GA secondary to AMD. The rate of GA growth was evaluated at baseline, 6 months, and 12 months. In each registrational trial, over a 12-month period, the primary analysis showed a statistically significant reduction in the rate of GA growth in patients treated with IZERVAY compared to sham or the placebo. Slowing of disease progression was observed as early as 6 months with up to 35% reduction in the first year of treatment. For SYFOVRE, the approval of SYFOVRE is based on the positive results from the phase 3 OAKS and DERBY studies at 24 months across a broad and representative population of patients. SYFOVRE is approved for GA patients with or without subfoveal involvement and provides dose flexibility for patients and physicians with a dosing regimen of every 25 to 60 days. In the OAKS and DERBY studies, SYFOVRE reduced the rate of GA lesion growth compared to the sham and demonstrated increasing treatment effects over time, with the greatest benefit up to 36% reduction in lesion growth with monthly treatment in the DERBY study occurring between months 18 to 24. So as you can see, a reduction of 35% for IZERVAY and 36% for SYFOVRE, so very similar in efficacy. For more specific information at the different evaluation steps and more information about reduction in comparison to the sham, refer to the product labels for each respective product. Now a comparison of IZERVAY and SYFOVRE based on the approved product labels. The active ingredient in IZERVAY is avacincaptad pegol as an intravitreal solution, and for SYFOVRE, the active ingredient is pegcetacoplan injection, again as an intravitreal solution. The indication for both products is the same. It's the treatment of geographic atrophy secondary to age-related macular degeneration. And I should point out that this is the dry AMD, not wet AMD. Dosage and administration for IZERVAY is a 2 milligram administered by intravitreal injection, which is injection into the eye, to each affected eye once monthly, approximately every 28 days plus or minus 7 days for up to 12 months. For SYFOVRE, the recommended dose is 15 milligram administered by intravitreal injection to each affected eye once every 25 to 60 days. The dosage form for both are intravitreal solution. IZERVAY is a 20 milligram per ml single dose vial, and SYFOVRE is a 150 milligram per ml single dose vial. The contraindications for both products are the same: ocular or periocular infections and active intraocular inflammation. So if a patient has either one of these, do not use IZERVAY or SYFOVRE. For warnings and precautions, similar for both products. First, endophthalmitis and retinal detachments. For this, intravitreal injections generally may be associated with endophthalmitis and retinal detachment, so proper aseptic injection techniques must always be used when administering these products. Patients should be instructed to report any symptoms suggestive of endophthalmitis or retinal detachment without delay and should be managed appropriately. Also, neovascular AMD, also known as wet AMD, this has been associated with increased rates in both products. Also, choroidal neovascularization, similar to the neovascular AMD. There's also an increased risk of that. So patients receiving these products should be monitored for signs of neovascular AMD. In case of antivascular endothelial growth factor is required, it should be given separately from the IZERVAY or SYFOVRE injection. Also, risk of intraocular inflammation. This has been associated with the use of these products. As noted earlier, it's also a contraindication. So inflammation including vitritis, vitreal cells, iridocyclitis, uveitis, anterior chamber cells, iritis, and anterior chamber flare, and so on. Increased intraocular pressure, Acute increase in intraocular pressure may be noticed within minutes of either intravitreal injection. Perfusion of the optic nerve head should be monitored following the injection and managed as needed. In terms of adverse reactions, for IZERVAY, the most common adverse reactions were conjunctival hemorrhage, increased intraocular pressure, blurred vision, and neovascular age-related macular degeneration, or wet AMD. For SYFOVRE, most common adverse reactions included ocular discomfort, neovascular AMD or wet AMD, vitreous floaters, and conjunctival hemorrhage. I hope you found this video educational and useful. Please remember to like and share. Thank you.